So I want to begin with acknowledgments of the many people in the health system and the university who have contributed to our testing strategy over the course of the pandemic. I want to particularly acknowledge the Pepper Laboratory, Mike Feldman, Bob Challenger, and Irvin Shamkin. My health system colleagues, particularly Pat Sullivan, Nida Al-Rami, Kat Lee, David Ash, Roy Rosen, who worked on our offsite strategy, Judith McKenzie and Amy Berman in occupational medicine, and the many university staff led by Benoit Dubé, who are working alongside the health system in establishing plans for the fall semester, and not least our infection prevention physicians that you see listed there, who have been integral to all of this. So this headline says it all, I think. We're months into the crisis, and on Monday, the New York Times headline read that U.S. cities are still lacking testing capacity, and that is no less true here in Philadelphia than it is on the West Coast, which is most heavily affected at the present time. The city has tested about 160,000 citizens as of this morning, and of those, about 26,000 have been positive. So at the beginning of the pandemic, our testing resources were severely constrained. We were limited to send out primarily to the Pennsylvania Department of Health Laboratory and had very limited in-house resources. But our capacity has certainly grown over time. But I don't think it's unfair to say that it has barely met our clinical needs. The demand has increased throughout the pandemic. Capacity has not kept pace. Although we have not actually run short, we would be testing more people if we had more capacity for sure. Particularly asymptomatic individuals. And as the demand grows in other parts of the country, we're actually seeing some diminution of our own capacity, particularly for the most rapid turnaround tests. So in our current state, the Pepper Lab has the capability of about 3,000 RT-PCR tests daily using 7 different platforms. This gives us an excess of about 1,000 tests beyond our clinical needs every day that we're able to share with other institutions, and we're frequently asked to assist other institutions in their testing. And it gives us an excess capacity of about 30,000 tests per month. So as we move into return to campus, that gives you a sense of what our in-house capacity is at the present time. As we acquired more capacity, we lowered our threshold for symptomatic patients and staff and began to test those with less severe symptoms. We began to have a demand pretty early on for testing patients who were undergoing at-risk procedures, aerosol-generating procedures, laboring mothers. As you heard in Scott's presentation earlier in the afternoon, there were a substantial number of pregnant women, substantial percentage of the pregnant women that we managed during the pandemic who were COVID positive. And then there was concern among those proceduralists who were doing aerosol-generating procedures. They wanted to know whether their patients were positive or not, and the best that we could do was a single test, particularly for elective procedures. And we were using our rapid testing capability for those. That did not, part of the justification for that was to preserve our PPE, but in fact, concerns about sensitivity and specificity did not translate into, or translated into, staff continuing to use the highest grades of personal protective equipment. All told, in the course of the pandemic, we performed 92,000 tests with a positivity rate of 12%. So the city has performed 162,000. All of our 92,000, of course, are not in the city. About a quarter of those are performed at Lancaster General and many others in Chester County and Princeton. So I would estimate that we've probably performed 25% to a third of all the tests done in the city to date. In a future state, we're hoping for easier sampling methods, faster turnaround times, better pooling capability, and larger capacity devices, which are on order, that will be necessary to increase our capacity. And I think we'll hear about some of these in the talks to follow. So this is our offsite testing site in West Philadelphia that we stood up in about 36 hours in mid-March and has processed thousands of tests. We have 2 offsites in Philadelphia on West Market Street and farther out in the city, and 1 in the suburbs. And these are the results from those sites. This is the testing volume Our highest volume week was in early May, but since early June, more of our samples have been obtained at our suburban site. And you can see that at our peak, we obtained about 1,900 tests between our suburban and city sites. The positive results peaked a little earlier than the peak of testing. That occurred in early to mid-April, and what we've seen is that the Philadelphia site has had a higher positivity rate than the suburban site, peaking at 36% in the April timeframe, and now down to about 4% in the city and 1% in the suburbs. This is a zip code map taken from the city's website, and I've been tracking this throughout the pandemic, looking at the zip code where the university is located, 19104 in Philadelphia. You can see on the left that among all tests performed, 13% have been positive throughout the pandemic. If you go back to the end of April, which was around the peak, at about the end of the first 2 months of the pandemic, the positivity rate then was 31%, and it's now fallen to 13%. The map on the right shows you the positivity rate in the last 2 weeks, which is now 2.9%, and that's been falling steadily since early June. So we've been trying to answer several questions. Why should we test? Who should we test? When should we test? And how should we test? And a corollary to that is how much is it going to cost us to test? So I think the reasons for testing are pretty clearly outlined here. We want to establish a diagnosis. We're also interested in establishing a prevalence in the population. There is a strong, I'll call it an optical sense, a desire for a sense of safety for our hospitals and our campuses, a strong desire among proceduralists for testing asymptomatic individuals. And then as we increase our capacity, we want to test more asymptomatic individuals in the adult population. As campus reopens, there's a desire to establish point prevalence of COVID-19, rapidly identifying persons on arrival to the campus so that we can test, track, quarantine, and trace individuals very quickly after they return, realizing that in the 19104 zip code where we live, the test positivity rate is going to be low, and among that population until recently, the college-age population until recently, it's probably been even lower than 3%. But bringing in people from all over the globe and the country, at least as we've planned until recently, we'll have an amalgamation of prevalences from around the world. As we approach this, we're assuming that our current in-house capacity will be the maximum that we have, and so that we're going to have to seek additional support outside the organization in order to do this. So who should we be testing? Well, there's consensus, of course, that we should be testing anyone with symptoms, as well as asymptomatic patients. We're testing virtually all hospitalized patients at this point, as well as those undergoing procedures. In the interest of the staff, we're spending long periods of time with those patients. Travelers returning from hotspots is a controversial issue at this point in time. We're trying to discourage that travel, but we're beginning to see people returning with positive test results after going to the South, Southwest, and California. And of course, we have announced that we're going to test students returning to campus. So when should we test? Stephen Kimmel in our Department of Biostatistics and Epidemiology laid out these 5 scenarios for us and looked at the probabilities of returning positive tests in these populations using a prevalence of under 1% and a sensitivity of the test of about 17%, the RT-PCR. So the scenarios are as you see here, and the results indicated to us that the best scenario for us in terms of detection, maximizing the number of positives and minimizing the number of negatives, would be the RE2, which is return to campus, testing twice on campus, which will give us a detection rate of about 87%. And because of that, that's our intention to go with that plan. So how should we test? Right now, our plan is to use nasal swabs for RT-PCR. We need easier, less time-consuming options and are looking forward to using saliva and point of care in the not-too-distant future. Batch testing has been under consideration, but has another number of limitations for us. And then we're looking forward to some of the newer technologies becoming readily available. But none of these are expected to be available to us at scale, which is essential for return to campus. The last thing that I want to mention is that we're implementing a symptom tracker for the detection of individuals on campus, students, faculty, and staff who will get a green card, so to speak, to enable them to enter our facilities. They will have a push question sent to them every day. They'll answer the question. If they have symptoms, they get a red pass, and they have to reconcile the red pass through the flow process that you see on the right. So it'll be a daily symptom tracker that will lead to an algorithm that points them to testing and then quarantine and then contact tracing.